If you read manuscripts at face value, you assume that the results and the conclusions are undeniable. That research paper you just pulled off PubMed was published in an academic journal, sometimes a very prestigious academic journal, and therefore you should take the conclusions for what they are: scientific fact. And you should incorporate them into your routine clinical practice. Consider the Socrates trial, for example, which randomized over 13,000 patients with minor stroke or high-risk TIA to either aspirin or ticagrelor. The objective of the study was to see which agent was associated with a lower risk of a recurrent stroke, myocardial infarction, or death by 90 days. It was a negative study. The conclusion statement in the New England Journal of Medicine paper reads like this: In our trial involving patients with acute ischemic stroke or transient ischemic attack, ticagrelor was not found to be superior to aspirin in reducing the rate of stroke, myocardial infarction, or death at 90 days. But the fact of the matter is, ticagrelor was associated with an 11% absolute risk reduction in the rate of the primary endpoint, with a 95% confidence interval that spanned from 0.78 to 1.01. For those of you without a background in statistics, that basically means that if this study were replicated 100 more times, in 95 of those trials, ticagrelor would reduce the risk of stroke, MI, or death by as much as 22%, or there would be a chance that it would increase the risk of those events by 1% when compared to aspirin. 95 times out of 100, ticagrelor would be practically 0% better than aspirin, or it could be up to 22% better than aspirin. Think about that. Now let's think about the Symphony 2 trial, which was published in Lancet Neurology, and this trial enrolled nearly 100 patients with idiopathic normal pressure hydrocephalus, and randomized these patients to early lumboperitoneal shunting or shunting that was delayed by 3 months. The primary outcome was functional status using the modified Rankin scale score at the end of that 3-month period. Because it was a major surgery, nobody was masked to the treatment assignment. Compared to the group that was not shunted, the shunt group were 61% more likely to have an improvement in the modified Rankin scale score, p-value of less than 0.0001. But imagine if you were a patient in that trial, you were consented and you were told that you'd be randomized into one of two arms. A, you'd get no different treatment right now, but after 3 months you'd get to have a major surgery, which we think is effective for your condition. Or B, you get that major surgery now. Right now. How do you think that people are going to feel if they get stuck in the arm with a delayed treatment? If you consider these trials at face value, Socrates and Symphony, you'd be led to believe that ticagrelor is no more effective than aspirin after stroke for preventing any vascular events or death. And you'd be convinced that lumboperitoneal shunting improves functional outcomes in patients with normal pressure hydrocephalus. But if you really look at the data in detail, if you really parse out those numbers, you comb through the methodology and their results, maybe you'll arrive at entirely different conclusions. And it's not my job to tell you how to interpret these trials. I'm going to let Dr. Ali Hamedani do this. He trained in public health and biostatistics at the Johns Hopkins University, and together, he and I are going to talk about some of the more common biases you should recognize in the literature, and we'll go through some of the more interesting examples of how you can be really misled by the conclusions of a published manuscript. Stay with us. All right, let's do this. Jim Siegler here for the Brainwaves Podcast, and joining me this week for another installment of the I Wonder series, where I get to ask Ali Hamedani any question that I want, is Dr. Ali Hamedani.
I am a neuro-ophthalmology, attending now after the past few weeks. But in addition, I have a background in epidemiology. I got a master's in epidemiology from Hopkins while I was in medical school.
So when we were kind of preparing this topic, you came up with this framework for the show where we go through the process of first designing your own study and then critiquing the methods of another study and then also interpreting the results of other studies. So let's start from the first thing where we talk about designing one study and preventing bias. So what is your definition of a bias in the literature, and how does one kind of try to avoid that in producing their own research?
Sure. So bias basically refers to an association or relationship that you find within a study, but that's not representative of the population from which that study population was drawn. In other words, we can never study an entire population at once. It's just not feasible to study every single person in the universe. But what we can do is study a subset of them, and that's the study population that we've sampled. And we assume that any relationship that we find within a study represents the population at large, and we further kind of assume that that relationship is causal, or causal inference is kind of what that's referring to. So in short, bias represents a situation in which what you found within the study does not represent the true relationship or association in the population at large.
So biases can be introduced by both the investigator or investigators, or they can be part of your own interpretation of the data. Most of the time, in good papers, the authors will acknowledge their own biases, selection bias, reporting bias, and other times, what you may think to be the truth will skew your own perception of the data that's presented, a bias called anchoring bias, which we'll also talk about. But before we even get into the biases, most of which we won't have time to cover in this show, there's already a bias inherent to the content of any study that you're reading, a publication bias.
That's a little bit of a different type of bias in the sense that it doesn't pertain to the interpretation of the results of any one study, but rather it treats each study as a data point on its own and sort of looks at how you as a reader judge, whether an association is true or not. And so the idea is that you use multiple papers that you read as kind of data points, and as a whole, you look at all of them and you decide, does the preponderance of the evidence suggest that this is real or not? But if only positive or novel findings are more likely to be published, then the literature base that you use to draw your own conclusions may be a little bit kind of skewed. So it's essentially selection.
What Ali is getting at here is that simply by producing a statistically significant finding, regardless of its accuracy or its external validity, that will increase the probability of that finding being published. If a study shows that consumption of Frosted Flakes is linked to frontotemporal dementia, that'd be a little weird.
Why do millions of kids start their day with Kellogg's Frosted Flakes?
And it might get published. But if 19 other investigators attempted to identify that relationship between Frosted Flakes and FTD, they might find nothing. How many journals do you think would be excited to publish that paper, saying that cereal intake doesn't increase one's risk of dementia?
Kellogg's Frosted Flakes. They're more than good. They're good.
So one type of bias that can arise is selection bias, and that has to do with bias that's introduced because of the manner in which you recruited study participants. And that can happen for any number of reasons, and the end result is basically that your study population is not truly representative of the population that you mean to study.
Otherwise known as cherry picking. Take, for instance, you've got a prospective cohort of patients who underwent surgical resection for GBM. You ask yourself, what are patient-level risk factors associated with the development of seizures? This is a totally biased sample of patients with a major brain tumor. First of all, you're starting with a cohort of patients who agreed to undergo surgery, whose surgeons agreed to resect the tumor, and who are more likely to follow up with their doctors and to treat their symptoms aggressively. You're not capturing the patients who might prefer radiation or temozolomide or bevacizumab. You're missing patients who might have brainstem involvement and they can't reasonably undergo surgery. And you're also ignoring the patients who might prefer more palliative measures. And these patients could be at higher risk of epileptic events. Or they could actually be at a lower risk because they're being treated with benzodiazepines for anxiety. Or they're being prophylactically treated with an antiepileptic already. So there are a lot of unmeasured or uncaptured confounders, and this would not be an ideal population to study for your specific research question.
One very classic example is there was a study that was actually published in the New England Journal a few decades ago that suggested that caffeine was a risk factor for pancreatic cancer. Coffee consumption was a risk factor, and it was a kind of a big deal, and there's a huge backlash against coffee drinking, which I say now as I'm drinking my iced coffee. But the reason that this was due to selection bias was that the study looked at people with pancreatic cancer compared to people who didn't have pancreatic cancer, and they asked them about their coffee consumption habits. But the problem was that control population wasn't just a random sample of everyone in the country. It was actually specifically drawn from a GI clinic's population of patients who often have acid reflux and other conditions where they find coffee drinking intolerable. So basically, the control population had an artificially lower rate of coffee consumption that didn't represent the overall population in the United States or in any other country for that matter. One thing to clarify about selection bias is that it's different from questions of generalizability or external validity, in the sense that selection bias results in an association in the study that is not reflective of what's happening from the larger population. In contrast, problems with generalizability or external validity refer to how the population you studied, even if the results are valid, may not apply to other related populations. For example, if you did a study of estrogen-containing oral contraceptives and the risk of stroke in young women premenopausally, you might design the study perfectly and draw all the right conclusions, but those results may not be generalizable to postmenopausal women because their biology is fundamentally different.
Another example of the limitations of generalizability would be when you preferentially target a population of patients who are most likely to benefit from an exposure or intervention so that you can demonstrate the most robust effect. Take, for instance, the Oratorio trial, which Dr. Perrone talked about in a recent podcast on MS. This trial evaluated the safety and efficacy of ocrelizumab in patients with primary progressive MS, who were relatively young and they weren't disabled. Now, this trial was positive in its primary outcome, which was a measure of disability progression by 12 weeks. So we can extrapolate this finding and say that ocrelizumab should be effective in other patients who meet those same criteria, patients who are young to middle age, who have minimal functional deficits, and who have primary progressive MS. But because this study was so constrained, we don't know from the results if ocrelizumab is effective in other forms of MS, or if it's effective in older patients, or patients who have more severe disability.
So I wouldn't call that selection bias there because you weren't biased in the selection of your study necessarily, but that would pose a threat to applying those results to other populations.
But in other ways, if you overgeneralize your sample, if you have a cohort of extremely heterogeneous patients, you may not get the right outcome that you find. And the only way you will determine a positive outcome or a positive finding is if you perform specific subgroup analyses. And this is also subject to all kinds of bias.
Yeah, so what you're getting at here is the balance between homogeneity of the study population and representing the diversity of the true population that you're studying. So in clinical trials, there are a ton of different inclusion and exclusion criteria. The goal is to limit confounding, which is a type of bias that we'll talk about later, and also to really distill down the effect that you're studying to what's most relevant. As you said, selecting patients who are at greatest risk for harm, who might benefit most from the treatment and things like that. But in real life, not all patients are the same like that. And so the challenge becomes when you want to apply those results to a patient population that's more heterogeneous.
Ali, what are your thoughts on trials or retrospective cohort studies that have a very heterogeneous population, a very large breadth of patients that they're capturing, and then later performing subgroup analyses?
I think that, as you said, there is certainly value in doing subgroup analyses, especially when you're starting with a population that's very diverse and you maybe have an a priori interest in a subpopulation. For example, if you're doing a study of TPA and outcomes afterwards, and you're specifically interested in posterior circulation strokes and how they benefit, then certainly makes sense to look at that. The challenge, and this is mainly an issue with randomized controlled trials where you did a lot of work up front to try and reduce confounding. So the challenge is that when you randomized or however it was that you designed the study to limit some of these biases, you didn't do that with subgroup analyses in mind ahead of time. So randomization works for the whole population that you enrolled into the study, but it doesn't really work once you start to dissect down to these different subgroups because those groups...
I'm going to jump in here and talk about this great subgroup analysis that came up on rounds the other day. The attending on the service referenced an older trial called ISIS-2. In ISIS-2, investigators studied 17,000 patients with suspected myocardial infarction. These patients were randomized to streptokinase, aspirin, both, or neither, and this was back in the 1980s, with the goal that either or both antithrombotic agents would reduce the risk of early mortality. And the investigators also pre-specified hypotheses that the two agents might reduce the risk of stroke and a few other vascular events. When the paper was submitted to Lancet, where the study was eventually published, the reviewers asked the authors for up to 40 other post hoc analyses. 40. The odds that at least one subgroup would show a significant relationship were very good, and this could absolutely be a chance finding. So the authors refused it. But the editors at Lancet pushed back, and they wouldn't publish the paper without the subgroup analyses. So ultimately, the authors had to concede. But they only agreed to do those analyses if they could also perform other subgroup analyses of their own, just to show how ridiculous it was that they were asked to do so many other comparisons, which could show findings on the basis of chance alone. What the authors wrote up, and what was published along with their article in Lancet, was a subgroup comparison based on astrological signs, Virgo, Sagittarius, etc. And among patients who were Geminis or Libras, those patients were actually harmed by the antithrombotic therapy, according to this analysis. While all the other patients benefited, you'd actually be more likely to die if you were given aspirin for a heart attack if you were born around June or October. Pretty crazy, right? So pre-specifying these subgroup comparisons ahead of time, before you go about testing hypotheses however you want, is really a key component to quality research.
So there's certainly value in using your a priori knowledge to both design a study and interpret the results later, but at the same time, acknowledging that our knowledge has limits.
And with that in mind, whenever I see a patient or whenever I'm evaluating a paper, I'm always trying to assess the biologic plausibility or the validity of those findings. Like, can we explain that caffeine, for instance, is biologically related to the development of pancreatic cancer, which it may or may not be? And if there's no biologic plausibility, I'm less inclined to believe that the relationship is a true relationship or a true reflection of what's happening in the world. Can you comment on how these biases also work in our interpretation?
Yeah, so certainly any relationship for it to be causal should make sense given what we know about the pathophysiology of disease and such. And any good epidemiologic study begins with a hypothesis that's based on prior data and prior knowledge about what causes different diseases. The caveat, though, is that our knowledge is very limited, and sometimes there are relationships that we discover first using large-scale data, and then later we learn the reasons for them. This comes up a lot in ecologic epidemiology, where certain diseases are more common in certain geographic areas, and that's led to some new discoveries about, for example, certain pesticides and whether they can cause different diseases or not.
And if you're not doing a prospective trial or not prospectively collecting data, but you're retrospectively kind of looking at previously collected data or data that exists in the medical record, say you go back and you want to find out how many patients have a history of headache disorder, and you want to see if patients with multiple sclerosis are at higher risk of headaches, and you chart biopsy 3,000 patients and you find that there is a relationship between headaches and MS risk. How do these kinds of retrospective reviews kind of influence the way that data is captured and then later interpreted?
So I think a challenge that's not necessarily unique to retrospective analyses, but is maybe more of a challenge in retrospective studies, is information bias, and specifically when you're asking about different patient experiences, recall bias, which is a type of information bias. So information bias just refers to error that occurs during data collection, and specifically it introduces bias, or it affects the outcome of the study if that error was not equal among everyone.
So let's consider this example. Say you want to know, are patients with psychiatric disease more likely to have a history of substance abuse than patients with cardiac disease? You go about this by performing a simple retrospective cohort of patients who are seen either at your hospital psych clinic or at the cardiology clinic. You find out that psych patients are twice as likely to have a history of substance abuse. But how do you know that means that psych patients are twice as likely to abuse illicit drugs? Why couldn't it mean that psychiatrists are just twice as likely to glean that kind of history from their patients than cardiologists are? Or what if psychiatrists are just twice as likely to document drug history in their notes?
In your proposed study of looking at headache in people with and without MS, information bias represents the sort of idea that a patient's recollection of their headache history may be inaccurate or incomplete. But also it would introduce bias if, for example, MS patients were more likely to recall their headache history, and people without MS might pay less attention to that sort of thing. So that's an example of recall bias. And the end result, again, is a situation in which, because of errors in data collection, you conclude an association or a relationship that is not truly present in the population.
Yeah. And then when you are confronted with these potentially inaccurate relationships or relationships that you don't expect or you don't have biologic plausibility to explain, how do you adjust for this kind of confounding in your statistical methodology?
Yeah, so confounding occurs during the analysis portion of a study. In other words, the population could have been perfectly selected and the data could have been perfectly collected, but to then analyze and interpret the data requires an understanding of confounding.
I'm sure most of you out there have some understanding of what confounding is, but like all things statistical, the concept of confounding will become much clearer once you hear the more formal definition of confounding and how investigators and statisticians account for it. Back to Ali.
So confounding is a situation in which the two variables that you're interested in, the exposure and the outcome, may be associated with one another, but not causative, one of the other. And specifically, it's because there's a third variable, the confounder, that's associated with both the exposure and outcome.
Imagine you're doing a study about the prevalence of peripheral neuropathy among various occupations, consultants, lawyers, secretaries, athletes, and you find that the secretaries are the most likely to have peripheral neuropathy. Does that mean that choosing a position as a secretary will put you at the highest risk of developing nerve disease? Well, we don't necessarily know that. This relationship could be explained by a lot of things. Maybe secretaries didn't become athletes because they had neuropathy to begin with. Or maybe there's a confounding variable associated with both being a secretary and having a neuropathy that we haven't measured or don't know to measure, like sedentary lifestyle, which can also lead to obesity and diabetes, and other physical factors that increase the risk of nerve disease. Or maybe secretaries spend more time typing at a computer than lawyers or athletes, and they aren't protecting their wrists from compressive median neuropathy at the carpal tunnel. Any of these variables can confound your results.
Sort of implicit in this notion is that, when we talk about the results of an epidemiologic study, we report an odds ratio or relative risk, that these are all measurements of the association between an exposure and outcome. What we really mean, or what we suggest, is that this is an independent effect of the exposure. Smoking is independently associated with a 7-fold risk of cardiovascular disease, in the population.
And when investigators report that exposure A is associated with outcome B, they usually mean that this relationship is independent of known confounders. But you should always make sure that the authors include all the relevant confounders in their model, and also to be sure that the exposures which are known to predict outcome B, like high cholesterol and cardiovascular disease, are still predictive of that outcome, even in this multivariable model. In retrospective studies, you can adjust for these known confounders.
So there are a few different ways of adjusting for confounding. First, you need to know what potential confounders could be. And this relies, again, on your knowledge of the mechanisms that cause different diseases and affect the treatment and outcomes of different diseases. It relies on your having read the prior literature to know, for example, what are the other things that people have identified that are associated with cardiovascular disease or something like that. And then, statistically, there are a few different ways of adjusting for confounding, too. And it kind of depends on whether the variables you're interested in are continuous or categorical, and what sort of analysis method you're using.
Here, Ali refers to multivariable regressions for the most part. But this is really only done in retrospective cohorts, or in certain analyses of prospective data. However, when you conduct a clinical trial, you don't have to adjust for these potential confounders because patients are randomized. And one of the benefits of randomization is that there's a theoretically equal distribution of the known confounders and the unknown confounders.
In clinical trials, we kind of get around the issue of confounding by performing randomization. In other words, if you have a population and people are randomly assigned to receive or not receive treatment, then in theory, all of the potential confounders were evenly distributed amongst that population. And therefore, when you assigned treatment or not, there's an equal chance that someone with a potential confounder got the treatment versus didn't get the treatment. I think one thing to keep in mind, too, as you design a study, especially a prospective one, is to make sure that your population is at risk for the outcome of interest. So one example would be in epilepsy trials, you need to have a sufficient observational period to allow events, namely seizures, to occur. If you did a study and you only assessed outcomes 1 month after treatment, your event frequency would be so low, it would be pretty hard to determine whether a particular medication were effective or not. A related concept is that the risk of an event happening is the same over time versus whether it changes.
This concept, the thought that the risk of developing a disease or developing progressive symptoms, is critically important for many neurologic studies, because the risk of certain outcomes may change with time. For example, the risk of seizure after a lobar intracranial hemorrhage is going to be the greatest about 30 days after the hemorrhage, while the risk of systemic embolism and systolic heart failure is kind of constant over time. And then the risk of aspiration pneumonia increases exponentially in the months after a diagnosis of ALS is made. So inappropriate selection of your study time period can introduce this length time bias. Or if you screen patients too early before symptoms of their disease manifest, by gene sequencing patients with a family history of Huntington's, for example, you may introduce a lead time bias. The outcome measure you're assessing in these studies, where you have introduced a lead time bias, may take longer than expected because you've identified patients earlier than you might have otherwise.
So, for example, if you were doing a medication trial in Parkinson's disease and you wanted to do kind of a pre-post sort of thing, so have the same patient do the treatment for a couple of months and then be off of it for a few months or vice versa, because it's a degenerative disease, there's the effective time that you have to take into account. So the second half of that observation period may be characterized by worse symptoms, just sort of not anything to do with the medication you were studying, but just because it's a disease that gets worse over time. So, for example, in that scenario, you'd want to make sure that you had a good balance of people who were doing the medication first and then the off medication period, and then the other way around.
Ali Hamedani, everybody. So there's no way we can try to cover all the unique biases in clinical and scientific research in a single podcast episode. And even by trying to cover some of the ones we did today, we definitely didn't get into incredible detail about them. But I hope that by illustrating some of these biases, and by sharing our perspectives, this information will make you a more critical reader of the scientific literature, and a more astute investigator. That wraps it up for another episode of Brainwaves this week. If you like what you heard, please let us know by rating the show on iTunes, Google Play, or wherever you get your podcasts. Again, I would like to thank Dr. Ali Hamedani for his incredible and easy-to-grasp explanations for the various biases in clinical research, making it more digestible for all of us. Much appreciated, Ali. The Brainwaves podcast is produced out of Studio 3 in Philadelphia, Pennsylvania. Jim Siegler, senior producer. Music for this week's program was courtesy of Jazar, Kai Engel, and Lee Rosevear. Sound effects by Mike Koenig and Daniel Simeone. Coming up in the next few weeks, we have shows lined up to tell you everything you should know about gadolinium, sleep-related movement disorders, and the newer therapeutics for Huntington's disease. If there's a topic that you'd like to hear more about, let us know by messaging us on Twitter at Brainwaves Audio, or email us at bweditorialboard@gmail.com. I'm Jim Siegler. Talk to you soon. We are, and if you go to Starbucks on 18th and South, and there's all kinds of bias over there.